I want to talk about why it is so important to use flowable composite to be able to design your own temporaries. Traditionally, when you go in to do your teeth, you are getting photographs, having a treatment plan. A dentist is talking to a lab, and the lab is giving a diagnostic wax up or a planning of some sort of how your teeth should be. Now, whether they do that analog with an actual lab technician and wax, or they do it digitally where they're designing it on a computer, and I don't care what system you're using to design it, what you're getting is a starting point. Now, most people think, and the way this procedure is done is that they think that planning is the best possible outcome of what your teeth should look like. And therefore, all of the underlying work that's going to be done by the time you put the temporaries in, meaning the preparation, the reduction, the occlusion, all of those things are dictated by this planning in most dentists' hands. And therefore, they go back to the patient's mouth when they're done doing all the drilling and all the time-consuming, arduous process, and they're putting the temporaries in from that planning, whether it be from a waxer or a digital planning. And they put it in, and they may like it and they may not. Now, doing this procedure for 25 years, I have tried to figure out the best possible way to save time in the chair with the patient, not from my perspective, from their perspective. Because if I was a patient sitting in a chair, I would not want to be sitting in a chair for 6 hours doing this procedure. If I could get out in 3 and it would be easier on me, it would be a more pleasurable experience. So number one, we're looking at what is the best way to be accurate and consistent in the chair while the patient is there. They have an expiration time in the chair. After about the 3-hour mark, they start to want to get out. I don't care who it is. And so you have to manage your time very efficiently in the chair, because the minute that you start and get someone comfortable, you're on the clock with that patient's tolerance to be in the chair. You're not rushing to get through the procedure. You're trying to be as efficient and effective to give the patient a good experience, and that's a very different point. Now, if you go through 3, 4, 5 hours of drilling teeth and you thought that your planning was perfect, you did all of your underground work to support what this design is, and now you put the design actually and integrated into the patient's face. And after practicing for 25 years, I've worked with the best dental technicians in the world, whether it's digital or analog, and it doesn't matter because they don't have the patient's head in their lab bench creating all of these contours to get it just right. They don't have lips that move. They can't see all of the little details that you're going to see when you're in the chair. And so the point of being able to use composite and create your own temporaries. Now, I don't care if you use it as a base, the diagnostic wax up or the digital wax up as a base, and you're able to modify it, but you have to really be able to modify it. The point is, when I'm in the chair with flowable composite, before I'm done with the temporaries, I am able to go through 10 different looks of what I think the patient should look like in one 30-minute session of being able to add and subtract. So therefore, if the wax up comes back and I don't like it, I can start changing it very quickly. Now, more than that, if I go in thinking that I want it to be like this, and then when I get in and start preparing the teeth, seeing the occlusion and seeing how the mouth works and how it actually fits around the face, more than half of the time, my mindset changes of what I really want the teeth to look like, because now I'm in the patient's mouth, feeling, seeing, and using their hard structure to see how these teeth are going to sit. Many times I have called down to my lab technician and said, I thought it was this, but you know what? Start doing this because it's different. I have a lab technician on site. So if I want to make those changes and get a better or a different base, I can do it in 20 minutes. If you, who doesn't have a lab technician by your side, you have to go with what you're given, let the patient go home, come back, be dissatisfied, lose trust, retake impressions, send it back to the lab, potentially change the preparation, which means getting the patient numb again, reducing more or less, changing the occlusion, getting a different wax up. Every time you do that, that's an appointment to the patient. That's an hour or two in the chair. That is discomfort. And to get your 10 looks to see what it looks like, it would take you 10 visits. For us, being able to control and design and understand before you start, you're going through those 10 looks in the matter of 30 minutes because that's how fast I can add length, subtract length, add volume, subtract volume, build a buccal corridor out, bring it in, lengthen the teeth, shorten the teeth, change the line angles, narrow teeth, widen teeth, rotate teeth, whatever detail I want to capture. I can do those 10 looks in the half hour at the end of the procedure when I am shaping patients' temporaries. That is the reason why it is so important, if you're going to do this procedure, to be able to control your own design. You cannot rely on someone outside to control your design because the design is the foundation from the beginning of the procedure and how you cut tissue, cut teeth, balance occlusions, build occlusions, all those things. And if your design, which more than half the time, I would say 80% of the time, is wrong. It's too far out. It's a little too long. It's canted. We didn't see the cant. Patient came in with oversized teeth and you're asking a lab to reduce and know how much to reduce to put it in the patient's mouth and not lose their lip and the lip falls. There are so many different things that you have to be able to control to get it right that it just can't be done outside. It has to be done in the patient's mouth. So that is a long-winded point for the number one most important thing, which is I get 10 looks of what these teeth should look like before I'm going to let the patient see. I'm listening to what the patient wants, and then I'm going in and trying to create it. Now, if I listen to what the patient wants, I sent my diagnostics out to a lab or designed it digitally and put it in, it was wrong, and the anesthesia wore off and the patient sees it and they think like, are you not listening to me? Like, this is not what we spoke about. Your hands are tied because now you're making excuses and you're just losing confidence. And it becomes harder every time to do what you know that you need to do because now the patient is saying, if this is what you thought and this is what you let me go home with, I don't know if I want to let you continue. When you go in to do someone's teeth, you have to be able to know all of the details to go from original teeth to final design. The details between original teeth and final design are about 100,000. And so when you're touching someone's real teeth and you're reducing their real teeth, you have to know why you are touching every part of every tooth that you touch, because that is the underlying foundation of what supports the restoration of the ceramic, whether it's a veneer or crown, an inlay, it doesn't matter, even when you're placing implants. If you are relying on someone else to design, they are not able to communicate and you are not able to truly see, and you don't know if it's correct when you start cutting teeth to say how much you're reducing. Sometimes people under-reduce and then the teeth become bulky. Sometimes people over-reduce and have problems with longevity with the restorations. Sometimes people prep at the wrong angle and the whole smile gets canted because the only way you can put the restoration, it has to have a path of insertion, and therefore if you're prepping at an angle and you want your tooth to be straight, ceramists can't make a straight tooth. They have to now put it in an angle because that's the path of insertion that you've prepared. The point is this: we are trying to teach our way, not for my benefit. It's for dentistry's benefit, because at the end of the day, it's you and the patient. You can't blame the periodontist. You can't blame the orthodontist. You can't blame the lab because the patient doesn't care. The relationship is with you. So if you don't know how to control each step of that procedure, you're just guessing. Even if you get it right 50% of the time, a 50% success rate in truly capturing what it is that the patient and you had in your minds of what you want them to look like is mentally exhausting for you, because you will just be beaten down with people saying it's too big, it's too small, it's crooked, it's too white, it's too dark. Those are all things that are initially controlled by your individual operating understanding of what the entire procedure is going to roll out like. It's just that simple. You must be able to design by hand.